Today, we are tackling a topic that is absolutely guaranteed to show up on your NCLEX: grief and loss. And, getting this right isn't just about passing an exam, it's about knowing the crucial difference between offering real comfort and completely missing a huge safety risk. So let's dive in.
Okay, let's just jump right into a situation that you are 100% going to see in your career.
So, picture this. You've got a terminally ill patient, and her husband just keeps saying everything is fine, completely refusing to talk about what's really happening. So, what's your first move? Your priority? Your ability to navigate that denial with therapeutic communication is exactly what the NCLEX is designed to test.
So here's our game plan for today. We're going to link grief directly to the NCLEX. We'll map out the key theories you absolutely have to know. We'll zero in on the critical safety alerts, and then we're going to lock it all in with some memory hacks and a super fast review so you walk into that exam feeling confident.
So let's just get right to it. Why does the NCLX care so much about your understanding of grief?
Because it's not just one topic, it's like a master key that unlocks a bunch of different areas. When you get a question about grief, they're not just testing you on feelings. They're testing your knowledge of psychosocial integrity, therapeutic communication, end-of-life care, and the big one, your ability to prioritize patient safety. See, it connects everything.
Now, to answer those questions correctly, you're gonna need a map. So let's take a look at the foundational models that really help us understand what our patients and their families are going through.
First up, we've got the one everybody's heard of, the Kubler-Ross model. But listen up, because here's the #1 NCLEX trap. The most important thing to remember about this isn't the stages themselves. It's the fact that it is absolutely not a straight line. It's not a step-by-step checklist.
A person can literally bounce from denial to anger, jump over to bargaining, and then fall right back into denial, sometimes all in the same conversation. Your job isn't to push them to the next stage, it's to be present and provide support right where they are in that exact moment. Okay, now for a slightly different way to look at things. The dual process model sees grieving as more than just sitting with sadness. It's actually an active balancing act.
You see, healthy grieving involves swinging back and forth. You have these loss-oriented moments where you're really confronting the pain, and then you have restoration-oriented moments where you're figuring out how to rebuild, how to live in this new reality. It's a dynamic back-and-forth process.
All right, let's check out our next model. This one lays things out as more of a progression over time. But remember, people can still move back and forth between these phases.
Knowing these phases is so helpful because it helps you predict what your patient might need. Someone in that initial shock phase, they need you to be present to ensure safety. But someone in reorganization, they might need resources and encouragement. Your communication has to match the phase they're in.
Okay, this is where we need to get serious. This is, without a doubt, one of the most important parts of your job. The theories are great, but being able to recognize risk, that's everything.
You have to be on high alert for these types of grief. Anticipatory grief, that's exactly what the husband from our opening scenario might be going through. But even more dangerous is disenfranchised grief. That's grief that society kind of says isn't okay, so the person feels like they can't grieve openly. That isolation is a massive, massive safety risk.
And that brings us to maybe the biggest NCLEX trap of all, knowing the difference between grief and clinical depression. They can look really similar on the surface, right? Sadness, fatigue, but the core difference, the thing you have to look for, is self-esteem. In grief, self-esteem is still intact. In depression, the person feels worthless. That distinction is absolutely critical for patient safety.
Okay, quick gut check. I'm going to give you 2 patient statements. Which one is an immediate red flag for suicide risk? The first is, I can't imagine life without them. The second is, I'm worthless and I don't deserve to be alive. Which one requires you to act right now? It's that second one. The statement about being worthless points directly to depression and an immediate risk. The first one, while heartbreaking, is a very normal expression of grief. Knowing that difference is a priority nursing intervention.
So now that we have the core concepts down and we know the safety alerts, let's get this stuff locked into your brain so you can pull it up instantly when you're sitting for that exam.
I really like this model because it changes how we think about grief. It's not just something that happens to you, it's active work that you have to do. This is the tier model.
Think of these as the 4 jobs of grieving. You can't skip any of them. T is for to accept the reality. E is for experience the pain.
A is for adjust to the new environment, and R is for reinvest in a new reality. TEAR. It's a simple, really powerful tool to help you remember the whole process.
All right, let's put it into practice. Here's a classic NCLEX-style question. A client's partner died 14 months ago. The client says they're preoccupied with the deceased and they're unable to function at work. As I'm reading that, what are the keywords that should be jumping off the screen at you?
The answer is prolonged grief disorder. And the two huge clues are the timeline, 14 months is more than 12, and the functional impairment, the inability to function at work. And what's your first action when you suspect this? You got it, always assess for safety.
Okay, deep breath. Let's wrap this up with a super fast, rapid-fire review of the absolute must-know points. Ready?
First up, uncomplicated grief. Remember, this is the normal, expected response. It feels awful, but it's not a disorder. It can include physical stuff like headaches, sadness, even that classic brain fog. It's all part of the process.
And then you have prolonged grief disorder. This is your big red flag. This is when that normal grief process just doesn't resolve and it keeps disrupting daily life past that 12-month mark for an adult. This is when we have to intervene.
So if you take one thing away from all of this, let it be this. As a nurse, you are not there to fix grief. You can't. Your job is to be a therapeutic presence, to create a safe space for that incredibly painful process to happen, and to have the clinical smarts to know when normal grief has become a safety risk that needs a higher level of care. That right there is how you provide truly safe and effective nursing care.